private sector, we're facing poor governance, under-regulation, escalating costs, with a stagnant medical aid membership. And across the board, the feeling with healthcare providers is they're being a bit between a rock and a hard place, where policymakers and regulators kind of know that regardless of how bad the situation is, healthcare providers are still going to turn up for work and are still going to deliver care. And it's under this kind of stress and this kind of chaos, if I can use that word, look at what's available to healthcare providers at the moment. We know there's a massive unemployment. We know we're training and we are graduating more GPs and more specialists than the country has space for. I'm at this pediatric conference, as I said, in PE at the moment. And I've just had two conversations with two of my colleagues, very senior pediatricians in the state sector, telling me about the diabolical state under which they are working. Not necessarily the infrastructural things, because some of them are in the very good quaternary hospital. It's the staffing and the teaching and the aging population, and just no new posts available for training specialists, and yet the specialist population is aging. So what are the options? When there are no posts, well, we've been told by our Minister of Health will go to the private sector. Well, we know that that's just not always possible. And we know that in some disciplines, there are areas of the private sector that are saturated. We'll leave the country, wait patiently. And while we're doing this, all in this milieu of increasing cost in the private sector, stagnant medical aid growth, increasing out-of-pocket expenses, which is hampered by the unemployment rate and therefore no free cash in the economy, moving towards hospital gap cover and the insurance models, as Christoph was talking about earlier, and as I've mentioned, limited space in the private sector. And all of this under this feeling of persuasion manipulation. Where are we in this process between managed care and quality of care? And I'll go through some of the philosophies and understanding that I face as one of the leaders in healthcare, and particularly in the private sector, and the kind of discussions that I have to almost sometimes mediate, and sometimes why as leaders we feel that we're actually acting as the PR for the funders, and we're certainly seen as sometimes as the goons for the funders by our members who are trying to lead, because of the level of persuasion, the manipulation sometimes we feel that we have to counter. And all along, we're looking at this quality, cost, and access. And I mean, is it time to rethink this and to make this a little less rigid? How does all of this fit in? Because the question for me is, are we ready for value-based care? Is value-based care the answer? Do we have the same understanding of value-based care? Because it's not a one-size-fits-all. Not every single aspect of medical care is compatible with a value-based care model to make it more affordable, more accessible. And interesting, in Christoph's presentation earlier, and I wrote it down, the impact of efficiencies such as managed care, value-based care, strategic purchasing is completely overshadowed by demographics. So the question then looks and goes like, are we shooting for the moon where there's actually lots of low-hanging fruit we should be focusing on to try and improve the system? Because this on the screen now is the stuff that we're facing. This is the stuff we're dealing with on a daily basis. Sector, and how we're trying to make it work, and how we're trying to convince colleagues to participate in every effort to review the coding system, to respond to the Section 59 report. What do we think about that? What about ITCHI? What about the Competition Commission? Fee-for-service is not working. Demand for cost neutrality from schemes. The need for us to engage with every single scheme individually. I think I've shown this slide to you before. Now the tariff determination, where they want to also suggest that we look at all coding and health technology assessments. So this, which is more specific to the private sector, on the back of what I've already said in terms of the consciousness of what's going on in the entire healthcare sector and looking for solutions. I just think we have to understand that if we're really going to start to work towards value-based care, that we really have to understand what it is, the level of collaboration that is needed, the upheaval it's going to, because you can't have fee-for-service, you have value-based care. I mean, it doesn't work like that. It just doesn't work like that. I'm putting my time on to remind me of time, and it's warning me. So this is why within SAPPF, a lot of you are aware of Sachi that I've been promoting. I'm sure to some of you it might seem ad nauseum, and I apologize for that, but I'm not going to stop. As the solution for the coding impasse that we have at the moment, because if we can't accurately demonstrate what we're doing through a coding system, well, then we're going to get absolutely nowhere. And we have to improve the weaknesses in the coding system, the weaknesses being that there is no coding mechanism for multidisciplinary teams. And if you don't have multidisciplinary teams working cohesively, you can't ever have value-based care. If you have a new coding scheme that allows for this kind of different type of reimbursement, it gives you an opportunity to really start looking at outcomes and measuring outcomes that are absolutely necessary, and not relying just on claims data that we get from schemes. And in most efforts where we've tried to have some kind of clinical overlay on the claims data, it really doesn't give you the answers that you want. We're having to centric data looks like. We need to take our lead maybe from somebody like ICHOM to understand, look at what they've worked running maybe longer. But that's what we need to be looking at, and we need to be able to avail ourselves. We need to collaborate with every opportunity to make this work. Because when we're looking at value-based care, simplistically, what we're talking about is that it is organized to deliver care. Now, this is a system we're talking about. This is not one intervention. And Roseanne this morning highlighted the point that if you are going to implement anything from the health market inquiry, that the recommendation is that it is a package. Don't break it up and don't cherry pick it and do piecemeal. And a very similar thing to value-based care. If you're going to do it, you're going to do it properly, then it can't just be managed care with more data, because managed care is working within the constraints of affordability. And the drive in managed care is to make things cheaper. The drive for value-based care is to give better value, better outcomes that are more patient-centric, where you don't rely necessarily on benefit options and scheme options. You can work on clinical care pathways, but clinical care pathways sometimes have to be patient-specific for this to work. Everybody in the value chain has to be assessed. Everybody in the value chain has to operate at the best efficiency that they can. This includes patients in their utilization of healthcare services. It includes healthcare professionals, doctors, making sure that we're measuring outcomes, making sure that we can work together as groups and that we can be part of the value chain where funders approach large practices or individuals, if it happens to be a specific small subspecial discipline, with the best outcomes and the best efficiencies, not just the cheapest, because we've seen that fail in managed care, where you go for the cheapest and all you end up with is higher length of stay in hospitals. So we need to really understand that value-based care is across the entire value chain, and that everybody is assessed. Everybody has an outcome that they have to present and make public, and so that patients are able to choose not just the doctor they want, but the funder they want. And if you look at this quickly in terms of the way it currently works, where in the managed care space, you have demand-side access management, restricted benefits, managed care protocols, profiles and outline management. So the profiles and outline management are using almost exclusively sure risk adjusted, but claims data with very little clinical overlay. And I know I've worked on these for 20 years in pediatrics, where we always have to sit down with the data and say, but let's understand the specific clinical scenarios. Let's understand the geography of that practice. So the supply side results in isolated, insecure, frustrated clinical practices who believe their clinical autonomy is compromised and whose administrative burden has gone through the roof. And we hear about this all the time, as I know you do. And in the system, the costly fractious system, unhappy, confused patients, zero clinical outcomes of any value for the patient. The outcomes are claims-derived outcomes that are about cost saving and inappropriate resources consumed. So this is not advancing easily. So the attempts up to now, not on value-based care, but on trying to curtail the system, trying to manage the cost, trying to see if you can get designated service providers that may or may not relate to quality, So there have been preferred provider networks, there have been direct payment arrangement, there's been peer review and profiling, which some of us in this call have been involved in, and you have to go and see your colleagues, and it feels like walking into the principal's office and sticking them up against the wall and giving them 6 jacks, when in fact you're trying to say, it's actually not what we mean, but in fact it is what you mean. You're saying you're the one who's an outlier, explain yourself. Cost-based clinical pathways, cost-based treatment protocols, and coding reviews. Coding reviews, as I said, are extremely difficult because you have to go and visit every single funder to try and to get the codes accepted. The perception then on the healthcare provider side is that there's obviously lack of trust, because we just feel that this is manipulation for cost. Managed care models are dictated to healthcare providers, loss of autonomy, lack of engagement in protocol development and benefits, patients coerced or access restricted, providers coerced to participate, lack of services in geographic areas, strict choices, and profiling, as I've mentioned, users' claims data. So none of this is perfect. And that's what the perception is. The other perception is this lack of professional autonomy. And sure, we talk about the fact that you have to be present, you're a part of the system, so we have to find solutions. So you can't just sit as a healthcare provider and go, what I say, what I think must go, and don't you tell me what to do, and I know what I'm doing, and I know the best for my patient. That's inappropriate. I mean, I understand that that's inappropriate. You have to have an understanding of the ecosystem in which we're working and all of those complexities. But the hospital at home services, the point of care labs and emergency units, the whole story around employment of healthcare providers, funder-driven guidelines and formularies, managed care contracts. Doctors feel like they are losing the grip and that they are literally being dictated to, and that this is all driving a cost base rather than a care base, rather than an outcomes-generated care base and decision-making. So the reality in this situation is that provider groups are not fully representative of cohesive. So even if a funder, in the best of intentions, reaches out to one of the provider groups who are well organized, and I think you appreciate that many of them are extremely well organized, they don't necessarily represent everybody. So how do you manage that? I mean, I understand that. Participation in managed healthcare opportunities, the healthcare providers in general are doing that because it's easy, not because it's better. Especially a direct payment arrangement, become a designated service provider, we'll pay you X amount, and then you don't, just don't charge more than that. People don't do that because they go, okay, that just makes my life easier, without thinking about where that goes in the long term, whether that's related to outcomes or quality. So you have uninformed healthcare providers, and interference in doctor-patient relationships, instances where doctors saying patients should be admitted and they're not admitted, where case managers are getting involved and the doctor-patient relationship is being affected, and then increased admin at practice level. So the point about all of that is really just to try and highlight how we've gone along this journey, and how, if we are going to move towards value-based care, which, as I said, definitely is, I don't believe, the golden bullet that's going to fix this. But any level of value-based care is going to require a massive amount of collaboration, understanding, to drive towards a true value-based, better access, better quality, outcomes-driven, patient-centered, outcomes-driven. That's the full thing, and it has to be across the value chain. So there's unified voice for collaboration and participation. That's what we've started through SAPPF and the South African Classification of Healthcare Interventions. Thank you to the large group of you that attended the meeting 2 weeks ago. We've started something. We understand that we have to embrace value-based healthcare. But how do we go about outcomes monitoring and reporting? This is not something that healthcare providers have the nous to do, necessarily have the funding to do. So this outcomes either has to be done on a use case basis, on a project basis. We still need to eat this elephant one little toe at a time, and it has to be a collaborative effort to make sure that the value is across the chain, that it's not just a value being driven from the funder to the healthcare provider. The patient has to come into it. There has to be this culture of group practices. And we're doing as much work as we can to try and change the culture of moving away from solo practice and fee-for-service. But if you don't develop group practices, it's going to be extremely difficult to develop service level agreements to make yourselves available for a funder to realistically look at a group and say that you can offer a huge portion of surgical care or obstetrics and gynecology care or pediatric care or whatever it is. This notion that there's a hospital where there are 5 individual pediatricians working in their own practices in one hospital, we've got to change that. I mean, that's just really not going to be helpful. And we are not going to get to implement value-based care until we start getting that kind of practice model involved. And then, as I've mentioned, improving the coding scheme and then driving adoption of electronic health records. I mean, you had a brilliant session earlier about AI and electronic health records. There's a lot of work going on at the moment. We're talking, all of us, SAMA, SAPPS, some of the funders, we're running webinars. We're trying to encourage our members to adopt electronic health record systems, because if you don't have that level of record keeping where you can start to develop meaningful data, you're not going to have value-based care. So there are a lot of steps that are required along this way. And on top of that, all the AI solutions that are coming on. You've got people sitting in offices with 30 years of files in a room behind them with their yellow folders in drawers. And now we're saying, well, just get an ambient scribe on your desk. You don't have to write again. Just talk to this machine that's going to write your notes for you. I don't think the uptake on that's going to be particularly good. I feel we have to walk these people along. We're going to have to get them from, if I can use my pediatrics, we need them from sitting to crawling to walking. To reaching out and grabbing with both hands with binocular vision. Otherwise, we're going to get nowhere. But this is the process that we're going to have to go through. So because if you're looking at value-based care, then we have demand-side value purchasing, contract support, optimal clinician-patient interaction. The contract support optimal clinician-patient interaction, so the patients are getting what they want from the doctor or the healthcare provider that they choose to use, who has been appointed or funded by the funder because they have proven to be the best, most efficient, most affordable, etc. So rewards effectiveness and appropriate benefits, as I've just mentioned. So then on the other side, you have healthcare providers who think the clinical autonomy has been restored, patient-centered integrated teamwork, happy clinicians in teams. Now, to get happy clinicians in teams who've never worked in teams before is a bit of a misnomer. It's going to take a long time before people are going to say, I'm happy. Because I can remember when I came into practice 30 years ago, what I was told was, don't go into a partnership with somebody, you've got one marriage. And you know how hard that is to keep that one going. Don't get involved with somebody else. And now we're looking at it 30 years later going, that's what we should have been doing all the time. So you have satisfied patients, continually improving outcomes, and then reduced waste. Because it is literally between fee-for-service and value-based care. The one doesn't really work with the other. Unless you have sections of medicine, as I said, it's not one size fits all, where you may well run a fee-for-service model on some parts, but on others you'll go for value-based care. And if we quickly look through that, one of the main things that comes out of this comparison is that there is shared risk. At the moment in the fee-for-service model, there really isn't shared risk. So getting shared risk and getting healthcare providers and funders to understand what shared risk means. And I know we've had lots of conversations with some of you around shared risk, and some of us understand it, but it is a concept that we're going to have to get the healthcare industry to understand. But what is shared risk? At the moment, you can't ask somebody to share risk when they feel like they're being manipulated into a contract that is purely cost-based with very little upside for them. And that's the way it's being perceived. So we need to show that value, and we need to understand the risk sharing. I'm nearly done. And this is just a few things coming through where you're wanting to shift from fee-for-service to value-based care, where you need to have care coordination across the system. So care coordination means the teams. It needs a mechanism to recognize teamwork, to remunerate teamwork, to code for teamwork, and for teamwork for them to demonstrate the outcomes that they have with the correct performance metrics. Second point there, to define the clear metrics. And that's why I mentioned earlier, to maybe have a look at what ICHOM is doing and not just having to look at length of stay and use of PATH and RAD and readmission rates. There are other things we need to be looking at. And then risk management. As I said, there needs to be shared risk, shared understanding through multiple sources. And then the last ones are really around staff education, patient engagement, technology adoption, and continuous improvement. And this fits very nicely into what we were talking about in the session before lunch around adopting technology and driving that, educating staff, and then patients have to be part of this, have to be patient-centric. Because the people at the end of the day who are going to make the decisions in a value-based healthcare model has to include the patient. They have to have sufficient information, so everything that is measured has to be made publicly available so that patients can look at it and they can make decisions. If the option that they have chosen with their funder is such that it doesn't allow them that decision, well, then they must have that discussion with their funder, or they must change their option. And that's how this needs to work. And then obviously continuous improvement and feedback. So to end then, I'm going back to this slide to say, let's be part of the solution. And I really mean that, and I really think that we can go a long way by concentrating on what I've got on this slide in terms of driving the adoption, about looking at the coding scheme, about driving the philosophy about multidisciplinary teams, looking at what employment contracts and service level agreements look like. Enabling practices to operate like this will take us a long way towards the implementation of value-based care, because those of you who know me well know that what this means in terms of collaboration, it only means one thing. And we go back to the good old standard, you'll never walk alone. Because if we're wanting to implement anything in this healthcare system, to look for reform, taking into account all of the complexities that I've mentioned, we're going to have to hold each other's hand and really understand each other and make sure that we understand each other and that we're working towards the same goal. Thanks very much.
The consumer is, oh, is that a new medical aid? Because apparently anything with med at the end is supposed to be a medical scheme. So we are a private hospital operator, and I have to underline, we are the youngest hospital operator in the country, 10 years this year. We are one of two post-1994 hospital operators in the country. And I say that deliberately because as a function of us being 10 years, we've been trying, Simon, to do what 10-year-olds do, which is to disrupt as much as possible. And hopefully I'll be able to show you some of the work that we have been doing. And then at a personal level, I wanted just to say, I'm 25 years in the industry. And at some point, obviously, I did some clinical work. There was a time I was running a GP practice in Cape Town. This is over 23 years ago now. I was running a GP practice, and I have to say this, which I'm embarrassed to say. I got bored seeing patients and asking them, you know, what their symptoms were, and the answers coming back with cough, shortness of breath, and then I knew exactly what to ask after that. It was, is there sputum? What's the color of the sputum? Do you have night sweats? Have you lost weight? It becomes very, very predictable. And so when I was in the middle of doing that, I actually felt that the one-on-one was not for me. Obviously, clinicians must still continue to do that. My burden was really how we can effect a system change. And I had seen some things that I thought we could change when I was at GP practice. And then to cut a long story short, a few years later, I ended up at Discovery. And I spent 9 years at Discovery. So I was 7 years doing clinical work, 9 years at Discovery. And for the last 9 years, I crossed the floor. So I've been sitting on the provider side. And so the reflections I will share today will draw from those many years of having been in different parts of the industry. By the way, I've also spent some time outside the country doing some work in India, Pakistan, Bangladesh, Kenya, Nigeria, and very fascinating things. If you thought medical schemes were the big thing, try and operate in some markets where 75% of your business is coming from people who are bringing cash for their cardiac bypass in a suitcase. And you are trying to do managed care and tariff negotiation, family by family. That's harder. This is something that many of you will be very familiar with. This is just the trends over the last, let's say, 20 years. with respect to the growth in the medical scheme population, where there has been growth and where there has not been growth. And I think this has already been touched on. This year is the dip that we have seen in the industry because of the younger people opting out. But the thing that should worry all of us is what has been happening, age 60 and above, is that we have an absolute increase in the number of people who are elderly in the industry. Now, we often talk about the industry has been stagnant for 10 years at 9 million lives. The reality is the industry has not been stagnant. The industry has been deteriorating in terms of demographics. So we've not been flat. We've actually been doing this. We've declined where we needed to grow, and we've increased where we needed to be managing. And I guess this is a number that many of you will know too well in terms of premium increases going into this year. And the basic point that I want to make here really is that I know we are gathered here as industry stakeholders. Okay, so we all have got our own things that we are doing, hospitals, we are funders, etc. But all of us should be concerned as citizens in this country about this trend. And nothing else from my talk is that, is the question that was asked earlier by Christoph. If we do nothing, we're going to be in a very terrible position as a country. And I like what HFA have put, like healthcare, 2030 healthcare. And then it was building a health system that we deserve. For me, that's really been my passion, is how do we come together and build a healthcare system that we deserve? And the deserve is this, that, and I will be transparent. I mean, obviously, I think I'm in this side of being young. I'm not old. There are people who are on the other side, but I believe I'm young. Anyway, but for me, the key thing is in 25, 30 years' time, what will this healthcare system be like? And because it's a healthcare system that we will need. We may not need it as much today, but at some point we will all be desperately needing this healthcare system. And I'm experiencing this every day with my own aging parents and how hard it is to navigate the system, knowing the people that I know and knowing how the system works. Mike Marshall and I were talking exactly about that. The system is complicated, even for us who are inside the system. And these are the things that we have got to fix. So my passion personally, which I translate into the work I do every day, is to figure how we can do this. And I think the fundamental thing here is that we will not be able to arrest the decline in what is happening in the industry if we do not redesign the system. And I think the key word that has been used throughout this morning is one of collaboration. And over the next few slides, I'm going to share some work with you of over the last, call it 18 years that I've been involved in how we can, as an industry, come together to effect the change that we all so desperately needed. So when I joined the private sector, this was back in 2008, 18 years ago now. 2006, Michael Porter had just released this this thing that would become the term that we use today, value-based care, and this was the idea. So value is you got to drive outcomes and you got to do it at the least cost possible. So I joined Discovery, and by the way, I was saying to someone earlier. So many of us were trained and raised by Jonathan Broombeck and Brian Raff, and we take pride in that because they really trained us in terms of how the healthcare system runs. In fact, there are many Discovery people. I was saying to them, if we were to take all the Discovery people, I think we will fill a few tables if we were all sitting together. But nonetheless, this is what I was faced. And I started to learn, after having learned shortness of breath and coughing, I started learning about length of stay, level of acuity, hospital costs, and all the things that you know very well. The famous was the loss ratio. I thought there was something lost. But anyway, it turned out it was just how they calculated from an insurance point of view. And we're doing some work on antibiotics at Discovery. But the thing that bothered me as a clinician coming into the private sector was that we were talking a lot about cost, but I was hearing nothing about quality. I was hearing nothing about clinical outcomes. And that bothered me in 2008, and in 2025, it bothers me the most. It's the idea that we have built a system that is focused. I think it was Jeremy earlier, we were just chatting. The idea that we walk into a room and we're talking about contracts for 2026, and the big driver is what price and what the discount is going to be. By the way, as a disclaimer, I did that for 9 years. You can ask Mark Bishop over there. He and I sat across the table. Mark, isn't that true? So Mark and I used to negotiate the biggest contract back then. I think it was 5 billion rands at the time between Discovery and Netcare. But what really bothered me is the fact that a lot of our conversations were around price. It was around discounts. It was around channeling. But no one was talking about quality. What is the value to the member? What is the value to the patients? And having talked about antibiotics, many of you will know that it was in 2009 that we actually established what was called back then Best Care Always. And you will remember, in fact, this is so old that some of the logos have changed since then. You will see the Mediclinic logo is the old logo. The clinic's logo has become orange now. HASA, I think Dr. Pomela HASA has now got a new logo. This is how old this is. This was 2009. We came together as an industry. It was Best Care Always. Eventually, we had 220 hospitals together, both private and public. We had 3,000 ICU beds, almost 1,000 theaters that were included. But the beauty was that it was across private and public. We had professionals that were involved. FITSA was involved, the Critical Care Society, they were involved. People like Professor Guy Richards, Professor Mervyn May, they were integral to it. There was a gentleman from, I think it was Ampath, Dr. Adrian Brink, who was integral in terms of this work. This was the entire industry. We had pharma coming together, and we built something that in this country, I still think, when I go back over time, I think this was the one moment we really did something special as a country when we came together to actually improve the value that the patients were getting. And these were the results back then. So these results were actually even published internationally. You can Google them, Google Best Care Always, and you will see this data here was published internationally. So this is CLEPSI for central line infections in ICU. You will see those coming down. This is ventilator-associated pneumonias coming down, all because of the work that was being done across the industry, where everybody actually was sharing what best practice was. This was the first time in this country we're talking about bundles. And actually, now we talk about bundles as if it's like, everyday language. But at the time, it was new. But the beautiful thing is that, and I've been around, the different hospitals, whichever hospital you go to, even if you just walk in the corridors, you're going to see something about bundles. You're going to see something about BCA. In fact, it's so funny. When I got to Busamed a few years ago, I asked the people, what does BCA stand for? They didn't know what BCA, but they were doing BCA bundles nonetheless, But the point is, everywhere you go, actually, people talk and do the bundles. And it came because it was an industry-wide initiative. We actually even had, as you will see here, we had international partners that we were partnering with. And you will see these are some of the articles that we did. In 2010, we started to think a lot about what about the voice of the patient? And we worked, and there were many people, and I should acknowledge Gary Cantor. He was quite integral in this work back then. HCAPS, we looked at it as a tool to understand the voice of the patient in terms of the care that they were giving. And this involved being able to get detailed information from the patients post-discharge. And we aggregated that and actually learned quite a lot. And we started sharing it with the hospital groups. And by the way, I think those of you who are in the hospital operators now, and you can challenge me during tea, but my view is it was after Discovery started to share this data with the industry, that the industry actually reciprocated that by measuring intensely, within their hospitals. Netcare Life, I know they adopted HCAPS. Mediclinic started with HCAPS. They ended up doing press gaining, but the rest of the industry followed a suit. But what it ended up was this. Now, this was funny because I was just Googling Discovery. By the way, I'm no longer at Discovery. I haven't been for 9 years. But I Googled Discovery Top 20, and this is because this is something that I led when I was at Discovery. We used the member data to pull together what are the top 20 hospitals based on patients. Just so you know, this I pulled online, And it's an online article. It's got nothing to do with me, but that is a Busamed hospital. True story. You can just go and check it yourself. It is a Busamed story. I just Googled Discovery Top 20 hospitals, and that came up. By the way, you will see here, these are the actual hospitals. I tried to fit all 20. I just managed to fit in the first 5 hospitals. Just joking. But this is how we got the voice of the patient back around the table. And by the way, you will see in the work that we've been doing at Busamed that we have maintained that. In 2012, I worked with Grant Rex, and he had approached us, because I think now you all know the work that he has been doing through ICPS. We did the first 6 cases with Grant Rex in 2012 to test whether this model can work, and it did. We were able to shorten length of stay. I remember this. Length of stay for an arthroplasty back then was 8 days. There was always guaranteed a day or 2 in ICU and all sorts of other things. And the best tools that we had at the time at Discovery was to manage it through limits for prosthetic devices, etc. But we actually couldn't control. This was an opportunity for us to work together to redesign how arthroplasties are being given. And the results have been astonishing. Now, these are the results. We've reduced ICU usage. We've reduced overall length of stay. We have a hospital in Nelspruit that runs like a day hospital. We have got orthopedic surgeons there who are operating and doing robotic-assisted arthroplasties, and they are great surgeons. They discharge arthroplasty cases same day, at most the next day. Now, that robotic-assisted work, it actually, the way was paved because the industry had already started to do this even before the robots came. But here is the thing. If you look at the average cost of different elective procedures over the years, and this is what you will see, there are costs like angiograms and CABGs, that have increased on average by 6 to 8%. And look at arthroplasty, well below a CPI. And by the way, Busamed, our number 1 discipline at Busamed is not internal medicine, it is not obstetrics. Our number 1 discipline is orthopedics, and we're big in arthroplasty. We could have been making more money now if we didn't do this in 2012. But the point, it's good for the patient. Patients, they mobilize, they go home, they can be productive and go back into the economy and deliver value for society. It is a good thing. This is what value-based care looks like and it feels like. If you look at this course and you project them, by the way, this data is from Discovery Health. I still have friends there. When I need data, I just ask them for data. So this is data, as you can see, is literally updated up until 2024. They gave me this data, and you will see this is how, if we had done nothing, I can assure you that arthroplasty, in fact, the cost of arthroplasty would have probably more than doubled if we had done nothing back then. And we've been able to keep it as flat as possible. As you can see in this line, arthroplasty, of all these procedures, it has been tracking quite well. This is what we talk about with respect to value-based care. It's about driving outcomes at the least possible cost. I've given you the example, the least possible cost, outcomes are better. Patients are going home, it's good for the patients. That's not a bad thing. And I tell our team all the time, we're not in the business of making money out of unnecessary admissions or keeping people longer in hospital, because we want people to be back in their homes, back into their economy. From there, we turned our focus onto another very important thing, which someone was also talking about. It's around the admin burden. And there were a few things there. I can't go into all of them into great detail. But what it was, you know, and I'm talking to you because you are funders. And I'm showing this. This is stuff that I led when I was at Discovery. So I'm not like, now that I'm on the provider side now, trying to get you to do things that I wasn't involved in. So one of the things that we did, I saw someone there at the back who was involved in this. In our chronic benefit, and I'm saying our at Discovery, chronic benefit, we used to have a system where someone is already a known, let's say, hypertension, we've already put the person on antihypertensive drugs. They need to add a line. We make the doctor to submit yet another form just to add another drug. It's completely unnecessary because, you know, the drug is already on the formulary. Why do we need to get the doctors to be submitting yet more forms? This was the pharmacy network. We used to manage it through, you know, very rudimentary pharmacy networks. All we did was any pharmacy that met specific compliance, that becomes the network. And it was a dynamic network. Patients had more access. It was much easier for the patients and the doctors to figure where to go. Similarly, prosthetic limits. Similarly, case management. This is very important, and Mark Bishop will remember this. We had done ARMs to such an extent that we were then saying, if we have transferred or at least are sharing more risk with providers, why do we still do managed care as if we are predominantly in a fee-for-service environment? And this was the work that we were doing. And these are the questions that we have to ask ourselves today, that even as we are talking about value-based care, we've got to think about how do we make it easy for everyone in the system. And I'm having lots of conversations with funders around, you know, this unnecessary admin burden that is in the system. Now, I wanted just to now shift, you know, in terms of what we have been doing and our thoughts. We've put together at Busamed what we call our clinical operating model, and it CARES for short. It stands for all of those things. I'm not going to go through it. Mark, please don't take pictures of our clinical operating model. This is IP. I'm joking. It's not IP. If everyone actually did it, we'll be delighted. What we have said to our doctors, and we have hundreds of doctors operating in our hospitals, we have said to them, all of us, when we're in medical school, we train in a particular way, but once you shift into private, we behave a completely different way. And the kind of things that we were talking about earlier. So we've said, all we're asking you is just do how academic medicine works. Evidence-based medicine, teams, you know, team-based medicine, and all of that stuff. I'll show you a slide on some of the work that we're doing. I had doctors, endocrinologists that we're talking to, and my colleagues are in the room. They'll attest to this. The endocrinologists, we're talking to them about insulin sliding scale. Now, for those of you who don't know what an insulin sliding scale is, it's very ancient. It's a very old thing, you know, in the world of medicine. But in our hospitals, including Busamed hospitals, the endocrinologists, they tell me, in ICU, you have as many versions of an insulin sliding scale as you have doctors who are admitting in the ICU. That's crazy. That's like abnormal medicine. And I tell our own colleagues in that it's not normal. It's not proper medicine. And so we've been on a journey to say, we want to do proper medicine in the private sector. And all you have to do is think of how we were trained as clinicians, whether it was undergrad or postgrad, we know what proper medicine is. And that's what we're asking our colleagues. And by the way, we have made very good progress in this respect. We have now transformed the way we are relating to doctors. In fact, when I talk to some funders, they don't believe that we have such cozy relationships with our clinicians. We are sitting on the same side, we're looking at the problems, and we're solving them together. And what we have done is really transfer and given the doctors much more autonomy, and we have given them actually what I call strategic decision-making in the hospitals, that they are part of actually building the system from a clinical point of view. Us as administrators, we are running the administration, but they've got to run the clinical side of things. And it has been working very well. So I'm sharing these. These are just some of the initiatives, and there's too many of them, but we have got large teams doing different pieces of work. And all of them, most of these are actually involve clinicians who are either leading or involved in making sure that we can improve care. I just want to give you just a few examples. By the way, the reason Vitality and Multiply is here is because for the first time, Busamed, all of our pharmacies, we have put in a fully equipped clinic systems, pretty much like you would have a Discam and at Clicks. And the logic is we can't just be waiting for patients to be sick so that we're admitting in ICU. If they're there for other things and we can help them to get their checks, let them get their checks and they get their points for Discovery, Vitality, and Multiply. By the way, we were the first hospital operator to be registered with Vitality, and I know that because that's what they told me then. I have friends at Vitality also. But I wanted just to give you just a sense of how important this work is. So this is something called antibiotic hang time. We have some teams that have been working on it. It's how quickly you can get an antibiotic in the vein after the doctor has prescribed. There's one hospital where when they started to look at it, they discovered that it took them 3 hours. Part of the reason it took them 3 hours is that they couldn't stock the medication in the ICU. The reason they couldn't stock the medication in the ICU is because they never knew what the doctor was going to prescribe. So we got the doctors involved. We said, give us your first line agents that you are going to use, whether it's pneumonia or whatever. We are going to stock them. And we cut down waiting time from 3.5 hours to 20 minutes. Okay. That's what you call value-based care. There is an implication in mortality and morbidity if you delay the giving of antibiotics for people who are critically ill in ICU. Let me give one that the people here will love. We've been doing a lot of work around the discharge process. One of our teams, in fact, I've got colleagues here, you can chat with them. Prisha is sitting in front and Dr. Ntabiseng is sitting over here. One of the big projects that we've been doing is around how we can quickly, believe it or not, quickly get people out of the hospital. Believe it or not. How do we quickly and efficiently discharge them? We discovered in one hospital that we could actually, in fact, we've been working now on pre-packing TTO so that by the time the patient is done with the procedure, they can go immediately. We were dealing with the ophthalmologists, and we learned that we had a number of ophthalmologists, and they were all prescribing different TTOs, doing the same cataract, but prescribing different TTOs. So we never knew which TTO to prepare until you actually realize which doctor is doing what. So what we then did, then we analyzed the cost of the TTOs. It turned out that the cost difference of the TTOs, it ranged from 500 to 900 for the same thing. So we got the ophthalmologist in the room, standardized into one TTO. We get it to be packed. Our pharmacy team, led by Prisha, used to joke that it took longer to do the cataract, it took longer to do the TTO than the cataract, the procedure itself. So now by the time the patients are going into theater, we have pre-packed. By the time they come back, their TTOs are ready and they are ready to go home. That's what we mean by value-based care. I could go on and give you all sorts of things across this, but the point is here, when we are working together, collaborating, and we are working together, these are the kind of results we can produce. This is some work that Prisha actually presented on antimicrobial stewardship, presented at the pharmacy conference. I wanted to share this with you. There's some very important work we're doing in diabetes. So our 2 hospitals in KZN are championing this work. It's KZN because KZN is the epicenter of the diabetic epidemic in the country. So what we actually discovered was that, and this was it was clinicians telling us that, yes, we're admitting patients for elective arthroplasties, but more than half of the patients that we are admitting have got uncontrolled diabetes. They are not coming for diabetes, but when they are in hospital, we notice that they've got uncontrolled diabetes. A statistic that that I didn't know up until recently was that actually your perioperative outcomes are worse if at the time they are cutting your sugar levels are high. And so we've picked up that a project. It started, Dr. Ntabiseng can tell you more about it. It's already live. We started a few weeks ago, and the chronologists are working with them, and we are going to be making some announcements. As you can see, we are already bringing together a number of key stakeholders. So for the funders whose logos are not here, you can talk to Dr. Ntabiseng during the break. Dr. Ntabiseng, why don't you stand? You will see she's already talking about 2030. So there's 2030, yeah. So that's 2030 healthcare, building a healthcare system that we all deserve. This is the results. Look at these stats. So from the last a few weeks, 57% of people admitted for electives have got an abnormal HbA1c. The average BMI is 31. The average BP is 150/90. Now, I showed these stats to our board a few weeks ago. They said, why are you intervening? Because we have got vascular surgeons here. They can pick them up in gangrene. They can pick them up. We've got cardiologists. We said it's good for society that we intervene on these things. And that's what we have started to do, ladies and gentlemen. And now we can actually see this data by scheme. So we'll be able to show you by scheme what's happening. We're collecting the data. But this is the thing that I wanted to bring to your attention, funders, is that this is from the Council for Medical Schemes. We should all be worried about this trend. You fully fund screening benefits that are being underutilized. Like, why is it that we cannot get this done? This is HbA1cs. The highest is less than 50% uptake. Discovery is here. Dr. Charlotte was here, Charlotte was here, is 25%. How is it that we fund 100% for amputation for gangrene? Okay? We fund that 100%, but actually we cannot drive this. And by the way, even if you look at proteinuria, you look at LDL, you look at the rate at which people are going to their optometrist or ophthalmologist in terms of looking at retinopathy, it's also underutilized. And this is the problem that we have. We are overutilizing the things that we should not and underutilizing the things that we should. We should be asking ourselves why that is difficult. This is our work. This is the result of the work that we have been doing. You will see patients are the happiest that they have ever been. Mark, you can take this picture. In terms of overall ratings, you will see every hospital has improved. You will see across all the different things that we measure, we've now gotten all of our hospitals to be above our threshold, and the results speak for themselves. All of our hospitals, except one, are comparing very well, not in internal ratings, but external ratings. In fact, in KZN, our two hospitals, Hillcrest and Gateway, they are the only private hospitals in KZN that are rated 4 and above on Google reviews. And this is some best of Durban work, also external recognition. And ladies and gentlemen, it just goes back to where I started to say, we've got to build, on top of what we have done on the cost side, we have got to build a lot more now in terms of patient experience, better health, patient safety, population health, and healthcare worker experience. And my last slide, Tonation, is this, which is my favorite slide now. In terms of healthcare worker experience, this is the result. Look at our staff turnover. Our staff turnover has moved from 26%. We are now well below the industry. And actually, our target is to get this to 12%. And if you look at the satisfaction amongst our clinicians, this is where we are tracking right now. And this is what we talk about. You know, when we're talking about quadruple aim, this is it. It's about best care, it's about best health at a population level, but also patient experience as well as healthcare worker experience. Thank you very much, ladies and gentlemen.
Thank you very much. Thank you, Dumani. Can we get Simon back online? Is it possible to have Simon? No. Good, is he on? Well, that certainly is so much to think about. I so wish I had an ambient note taker to summarize all of this for me, because I literally had to write it down. So, Simon waiting? Joining? Let's just wait a minute. I'm threatening to tell a joke now. Yes, Simon. Good, fantastic. Good to hear you. Good, welcome. Thank you very much.
I fell asleep watching you and I was jumping on very fast, so you didn't tell a joke.
Good. Okay, so I'm sure you followed Dumani's discussion as well. So I try to use AI, but I'm not really there. But I think the one thing word that you have said so many times is collaboration. I mean that is a key element that you all have raised now. Now we have funders in the room, and I'm sure we'd like to hear about that collaboration. And then the other thing that Simon, you particularly spoke a lot about is we have got to change the service care model. We've got to change that model. We've got to work in teams, and we need data. We need data. We need an EHR, and then a lot about the clinical autonomy, which you also spoke to. You speak to the doctors when you deciding how to get what drugs must be kept in the ICU for to reduce the hang time. And patient-centeredness is something you repeated a lot as well. So the patient-centeredness, the clinical economy, and then you spoke about happy clinicians and teams, and your doctors seem to be happy when you were rated. So at least those are the things that you've been raising. But now, if I listen at all of these conditions you've listed, saying, what are all these things that are required to get to value-based care? It seems a bit like saying all of the HMI recommendations must be implemented at one time, otherwise they're not going to make forward. And we all know that's not possible. No, things don't change in healthcare in a big bang way. Things change through phased and incremental implementation of things. So I'd like to ask you, if you buy into this concept that we have to take small steps, what are these next steps we should take? And how do we collaborate? How do we get the funders, everyone around the same table, to take these small steps that could lead to, in a decade's time or 2 decades' time? I've been in this business for 4 decades and I haven't seen much change. But in 2 or 3 decades, we could see that change. And what do we do? What are those next things you think you could do? And then if you want to go first, Simon, what would you like?
Yeah, thanks, Moshe. So Demani, brilliant presentation. I love your passion. And I think we all know people at Discovery, so I don't think you're too special. And if you just follow the lead from what was being said, is that in the New Zealand hospitals, what they've done is identify operational things that were easy wins, and because they were collaborative in their approach to doctors, and I'm sure got them all in the room and came up with a joint solution, things were easily implemented. So if we use that, so that, and what that does is that just shows that collaboration is possible. I mean, that doesn't equal value-based care, unless it also means that there's a cost benefit and patients are happy and they go home. And very often, when you do change something that's operational in nature, that you are going to get benefits down the road. So let's take that to the next level. For me, the next level is that although you can't mandate this because it's not regulated, there is an opportunity here for every health professional discipline or every hospital to find that one thing which is open to change and open to testing on a value-based healthcare model scenario. And that's what we need to be doing about. So in the difficulty with that at a discipline level, if we take, for example, neonatal intensive care, and we're trying to, there are going to be winners and losers when you bring in value-based care, and there are going to be winners and losers when you change that in any of the models. But the point is that it has to be adopted by everybody. So this is not something where we're going to bring in tomorrow across the board. It is something where we have to test the use cases. About 6 months ago, when I was talking to a large group of funders about the South African classification of healthcare interventions, the SACHI, that platform that's looking at revolutionising the way coding is governed and constructed, we presented a few use cases. We presented, for example, the review of of codes by general surgeons. They reviewed 130 codes. And the uptake of those codes by the funders had been dismal. It was requiring a lot of work from the surgeons and the surgical groups to go and discuss that with every single funder. So there's an example where a provider group looked at the coding systems that we need to have. There's opportunity here. So the funders could look at that and go, yeah, we'll accept 50% of them, but there are a few there that we won't. So how then do you make those fundable? Then build a value-based healthcare model around those things. If they are standard practice, if they are accepted, and they are gold standard, then they should be funded. So that's just one example. In my pediatric discipline, I could come up with a few more. But the portion of that for me is the way to do this. That's the level of collaboration. So collaboration for me is even for the funders and the hospital groups, and I'm really, really glad that you've got a hospital group on here. Because a lot of the work that you read around value-based healthcare, they talk about funders, healthcare providers, and then they talk about doctors and patients, and the hospitals seem to kind of have to fit in there. So I'm very glad that the hospitals here is absolutely critical. But along that value chain, somebody could start the conversation for a particular discipline and bring everybody in, just like Mr. Mayor's done in their hospitals, and you can drive change like that, one step at a time.
Thank you.
Yeah, thanks so much. I think I just want to echo what Simon has said there, and I just want to give a practical example. So when we started this work, you definitely have to start small, and you have to find I think actually our focus has always been to look for what pain points are amongst the clinicians themselves. You almost like have got to start with what they want done, and then you've got to work backwards on what we also need, done from a system point of view. And that's what we have been doing across all of our hospitals. And actually, the different hospitals have advanced more in different things, and that's because of the clinician appetite, in that hospital. So we now have got, clinicians who are driving M&M meetings properly. So, and I used to attend as many as I could. They will come in and they will meet as you will do in an academic setting. You discuss rigorously M&M issues, journal clubs, there's like antibiotic stewardship ward runs that are taking place led by clinicians, not led by pharmacists or the nurses in the ward. But that, as I said, you've got to almost like find champions in each hospital, and it can vary, it can be a pediatrician. By the way, we've got a neurosurgeon, who's passionate about M&Ms, and she's running it, and she's running it without like any involvement from the administrative staff. So you almost like got to identify what are the areas that the clinicians are also, where our patients in a way overlap. And then I think the one thing that I want to just say also is that I think where the industry is, and then talking now about the funders, is that we also need a mindset shift. And I'll tell you one of the things that, and I'm trying to be as respectful as possible because you are my clients, but one of the things that annoys me a lot is the idea that, that this work, overnight, it changes everything. And then everybody wants okay, now can we contract? Can you reduce your tariffs? Can we overall, your overall cost per event, etc.? It's never going to happen overnight. And I think for me, the key message I would say is that what we need is not to look at this work as, as short term and you look at it as a cost. You've got to look at it as a co-investment. So we've got the infrastructure, we've got the clinicians. You as funders, you never see most of your members, but we do. They're in our hospitals, we interact with them. You've got to see the infrastructure that we have as an opportunity to co-invest in terms of shaping how that infrastructure is designed for your own members. And I'll give you an example. In 2008, when we started Best Care Always, Discovery Health, the administrator, put in almost R1 million to get it going. And we were the only administrator at the time that put in money. What we need now is the funders that are sitting on large reserves is to co-invest in the system. And you can, and there's ways you don't need permission from the Council for Medical Schemes because the tariff regime is there. We can figure ways of how do you support players that are willing to innovate, co-invest with them, we measure. What you are sitting on is like gold mine in terms of the data, what's happening outside hospitals. We need that data to complement what we are seeing on the hospital side. Thank you, Boshoff.
Thank you so much. Dinesh, I've got 100 questions, but what's the time doing? Okay, so we have one last quick question. You started, Dumani, you set up this whole question about value equals outcomes over cost, the Porter question. Now, in that context, HQA exists and it's for 20 years been using schemes data. It's limited, but it's getting gradually moving towards outcomes measurement. It's established a prostate cancer registry now, which is soon going to start giving possible measurements. But how do we get that outcomes into the equation? Because you've spoken, you've shown some outcomes, but those outcomes that really matter to patients, how do we measure that, and how do we bring that into the equation? Because I think, to me, that is a missing part in the equation, that we struggle to measure that. And I really would like to hear your views on those.
I'll give you some thoughts. So part of the work that I started many years ago was actually around the quality focus. So Geraldine Timothy, she's still leading that work at Discovery. So I interact with Geraldine. So by the way, she was my classmate also. So I interact with Geraldine. So at Discovery today, most of the outcomes that they're measuring on the hospital side are still the things that we were measuring 10 years ago. It's like mortality rates, it's readmission rates, like it's basic things. Where we should be as an industry now, I mean, think of, and by the way, the funders, have got to keep up, because the pace of innovation on the provider side, I mean, now we're doing like robotic assisted work. I have a gynecologist who's been doing robotic assisted work in Gyne, but the medical schemes are refusing to fund, but we're taking the cost on us, because the point is, if the funders refuse to fund things like that, that means the whole system is going to lag behind, not relative to cost, relative to where the world is in terms of innovation. What we need from the funders is to innovate on the funding side. So in terms of outcomes, one of the, Dr. Ayanda, if I were to call it a conference resolution, Dr. Ayanda will know what I mean. One of the conference resolutions out of this should be that we work together on a standard scorecard on the quality side, and the medical schemes, they help us to consolidate and aggregate the data that they have, and we bring the data that we have, so that all of us are singing from the same hymn sheet with respect to quality outcomes. If we can at least do that, then we can all be doing the same thing and making sure that we are advancing. But if we are all going to be competing on kind of standards, and by the way, the breakthrough and how we got Netcare, Mediclinic, and Life together was, we said, yes, we're going to continue to compete, but there must be a minimum we set, that we say everybody has got to do this, and then on top of that, we compete.
Thank you. Simon, last word.
Yeah, thanks. Yeah, look, so the prostate cancer registry at HQA, in fact, was an idea that Phil Mackey and I took to HQA 5 years ago, and through them got Stellenbosch University Urology Department involved, and now it's taken that length of time to get to the registry, which is absolutely fantastic news. So I'd just like to pick up on the point of Dumani, because I want to highlight again, and I know that this word collaboration, he's given now a perfect example. And the example is, we all know what we want, we all know what we need. But there are people who can make it happen because they have the purse strings to make it happen. There are people who have the knowledge of what outcomes should be measured. And we need a group of people to commit to this and to run with it. The other way to do this is, Michael Porter, the other thing that he did was started ITRON, which is the International Outcomes Monitoring Organization. And they have a whole lot of clinical pathways and scenarios where they've already set out what those outcomes are and how they can be measured. know that in South Africa we like to make it South African and do it South African, but you also don't want to necessarily make a wheel that is one of it. So there is every opportunity here to use what's already being used around the world in many instances, and to see which of those is immediately, with tweaking or without, implementable in South Africa, whether that's around diabetes care, cardiovascular care, lower backache. All of that's available because the work's been done. It's been used in Holland, it's been used around the world. So it's there. We just need to get the will to get up and do it.
Yeah. Thank you, Simon. Yes, I just want to make this final remark. ICHOM has certainly been part of this whole development of the registry, but it's not only them, and other stakeholders across the world were also involved, including the Dutch. And then, but finally, the final thing was we have a different structure, different practicing mechanism, different regulatory environment, and those things couldn't be taken on without some adjustments that have been made. And that is what it is. You always need to localize international best practices because we are different in many respects. But at this point, I just want to thank the speakers and thank the audience. Thank you very much. Sorry they spoke so much you didn't get a chance for a question, but thank you very much. Thank you very much. Thank you very much. Simon, thank you.
Thanks very much, Bishop. Thanks,
Cool. So I think perhaps we're going to break for tea. We're going to have, if I can ask, you can come back at 3:15. Cool. And then we'll get started with the next session. Next one's going to be a bit of a longer stretch as we're finishing up and wrapping. Cool. Thank you. I hope you